So it will be
There you
around
go.
week 9, Thursday.
Let me know when you're ready.
Oh man.
All right, hello everyone. Today we're going to talk about another test that's called a somatosensory evoked potential, and it's abbreviated by the letters SEP, or sometimes it's abbreviated SSEP. So you'll see those letters used interchangeably to refer to this particular test. Like an NCV, it's going to give us information about how nerves are working in our body. But unlike the NCV, that only looks at peripheral nerves, the SSEP not only looks at the function of the peripheral nerves, but also the ones that are centrally located. So we can look at the function of both the peripheral nervous system and the central nervous system. Now, with a name like somatosensory evoked potential, do you think this is a motor test or a sensory test?
Sensory.
Sensory, of course, yeah, it's right there in the name. It's only a sensory test. So, if you had patients that came in and they were complaining of what we call motor impersistence, right? They can't hold on to something, it keeps dropping, or they have weakness. Would they be a good candidate for this test?
No.
No. Why not?
It's motor.
Yeah, because that's a motor issue and a motor symptom, and this does test the sensory portion of the nervous system. So what might they be complaining of in order to qualify to be a patient for this test?
Numbness, tingling.
Yeah, they could have numbness, tickling, they could have some kind of sensory, loss of sensation, something like that. And let's say that you had done an exam on them, maybe you were adjusting them for a while, it wasn't helping their symptoms, or maybe the symptoms are getting worse. So we want to see if they have an underlying pathology that's causing it. So we could run an SEP. Now, when you run an SEP, we stimulate a peripheral nerve, and we can do this on most peripheral nerves. However, there are two basic tests that are normally done. Just like the NCV, one is called an upper study, and the other one's called a lower study. Guess what the upper study tests? Yeah, the upper extremity, right? And the lower study, the lower extremity. So when you perform an upper study, we usually only stimulate one nerve. For the upper study, it's typically the median nerve, right? The median nerve, sometimes depending on symptoms, they'll use the ulnar nerve. For the lower study, we typically use the tibial nerve, and then sometimes we'll use the peroneal nerve. But usually it's the median and the tibial that are used. So what we're going to do in class is we're actually going to do an upper study using the median nerve. The way it works is we take that stimulator. Remember the stimulator that we used for the NCV? Well, we unplug the silver prongs and we put in some sticky or fixed electrodes, and we'll fix those electrodes to the wrist over the median nerve, right here. And we'll allow that electrode to stim them anywhere from 200 to 500 times. In class, we'll just do it 200. And every time that stimulator depolarizes that nerve, it's going to go up the median nerve, and we're going to track it by some recording electrodes along that pathway. The first electrode we put on is right here above the clavicle. If you feel your clavicle, if you go lateral from the medial portion of it, if you go on top of it, the superior portion, you'll see it kind of comes down. It makes a dip before it goes back up again. Right at this dip, that's where the brachial plexus is coming out. And so we can look at the depolarization that's whipping along that nerve, going through that brachial plexus under this electrode, which is called at Erb's point. Now, you guys have heard of at Erb's point before, but it's not this one. What is the one you've heard about?
The heart.
The heart, where we can auscultate the heart. So Erb must have been a pretty prolific guy, right? Because he's got a couple points and a palsy that I know about, right? This Erb's point, like I said, is above the clavicle. We put one of our electrodes there, and we can find out if the patient has some kind of entrapment or pathology that's slowing down that waveform from going all the way up from the wrist to that brachial plexus. It should take about 10 milliseconds for the depolarization to go from the stem here at the wrist to Erb's point. And what's going to happen is when we do this stim, we're going to get a graph of a waveform. So down here, we're going to see the lowest one we're going to see is the waveform that's created from Erb's point. And at 10 milliseconds, we should see a negative deflection or an upwards deflection of the baseline, right? This is the waveform, right here. Any deflection of baseline that goes up is considered negative. In electrodiagnostics, anything that goes down is considered positive. So N is for negative. So my N10, they call it an N10 marker. That's what we expect to see if it's a normal test. That we're going to see a depolarization or waveform with its peak around 10 milliseconds. The second electrode, I'm going to be placing on the posterior side of the neck, usually around C5. And then I'm going to be picking up the sensory systems that are the very fastest. Do you know which sensory tracts are the very fastest in our spinal cord, the most heavily myelinated? In the back of the cord?
Dorsal columns?
Yeah, very good. The dorsal columns, right? So we're going to be tracking this sensation that's coming up through the dorsal columns, and we're going to measure it at C5 level. We'll kind of have them bend their neck forward, feel for the spinuses to open, and put that electrode right between the spinuses there. We know that in about 13 milliseconds, we should get a negative deflection, right? We should get a waveform at C5. Now, sometimes, they usually put it at C5. Sometimes they put it anywhere from C2 to C7, I've seen. But usually they put it at C5, that's where we will do it. As the sensory sensation goes up through the dorsal columns, it's going to go up to the medulla, cross over, up through the thalamus, the internal capsule, and then it's going to terminate in the contralateral, meaning the other side, post-central gyrus. You guys have heard of that, right? You guys know about that? It's called post-central gyrus because it's post of what? What's it post of? The central sulcus, right? So this is not a fortune cookie, right? This is actually the sideways view of your brain. And here's the central sulcus. Which two lobes does the central sulcus divide?
Frontal parietal.
Yeah, the frontal and the parietal lobe. Very good. And what do we call the strip that's pre-central, right? That is in front of the central sulcus.
Central gyrus.
The pre-central gyrus, right? And what happens? What is that in charge of? What happens from that strip? The motor, yeah. So this is our motor strip. So the post-central gyrus is what strip? What do we call that? The sensory strip, right? That's where we're going to put this electrode because that's the sensory strip. Now, this strip of brain is what's called a somatotopic map of the opposite side of the body, right? So what that means is for every part of the left side of my body, I have a part of my right somatosensory strip right here, that primary sensory strip, that's associated with it, okay? And there's a drawing of that in textbooks. What do we call that guy? The homunculus, right? With the big lips and the big fingers and the little teeny tiny back. Because the size of his features are associated to the amount of real estate that's allocated to that body part along that sensory strip, right? So, so what I'm going to do is I'm going to put the electrode right over the spot that's associated with the wrist because I'm going to be stimming the wrist, okay? So that's what we're going to do. We're going to put the first electrode here, second electrode here, third electrode here, and we're going to measure how quickly that impulse goes up that sensory tract. We'll see if it's within normal limits, and then we'll know that the sensory tract is working correctly, or we'll see if it is slowed down, where we think that there's some kind of pathology that's causing a problem with the conduction. Any questions so far? Okay. So let's talk about what this means for our patients. If we stim here at the wrist, and we have an electrode at Erb's point right up here, and we know that that waveform should come in at about 10 milliseconds, but let's say the waveform comes in at 13 milliseconds, right? That's slow, right? It's slow to get to Erb's point. Since we're on the median nerve, what do you think, where could that nerve maybe be compressed that would cause a slowing?
Pronator
Yeah, maybe they have a pronator Terry syndrome, maybe ligamentous Struthers, right? Could it be carpal tunnel? No, it could be carpal tunnel because the carpal tunnel is distal to where we're stimming, right? We're stimming proximal to it and recording it here. But it could be pronator, it could be ligamentous Struthers, could be some kind of, maybe they fell and maybe their shoulder is compressing the nerve. Anything from here to here, basically, okay? So now, oh, and one other thing. If we know that it's slow getting to Erb's point, but we know that the latencies are good for C5 and the parietal lobe, can I say whether this is a peripheral versus a central nervous system lesion? Yeah, we can, right? Which would it be? Which would it have to be? Peripheral, right? It'd have to be peripheral because it's happening in the periphery. We know all the central structures are working okay. Does that make sense to you guys? So this is really good news because now I can differentially diagnose and know, hey, it's got nothing to do with the central nervous system. It's just the peripheral. So now let's look and see where it really is coming from. So let's look at scenario number 2. With that one, we have, let's say, we have the Erb's points coming in at 10 milliseconds, so we're good. But now let's say C5 is not coming in till 16 milliseconds, okay? So it's slow, and this one's fine. So if this is slow here, but it's okay here, where could a problem potentially occur? Yeah, so maybe we have some kind of nerve root encroachment because this is the area where the nerve roots are exiting and entering, for sensory, they're entering the cord. And if I have some kind of compression that's demyelinating, it's going to slow, right? It's going to slow that transmission and slow this up here. Now, which nerve roots go into making the median nerve? Which one's at the brachial plexus? C5, C6, C7, C8, and C1. All of them, right? So the median nerve is the one nerve in the upper extremity that all of the nerves from the nerve root go into. So we know that we could have a lesion not only of the nerve roots, but could I also have a lesion of the spinal cord that could cause this? Yeah, but only up to what level? Could I have a lesion in L1 that shows up on this test? No. What levels would show up? If this is fine, and this is fine, and C5 is where I'm seeing a slowing. What do you think? Could it be at C5? Yeah. Could it be at C6? Yeah. Could it be at C7? Yeah. Could it be at C8? Yeah. Could it be at C1? Yeah. All the nerve roots that go into making the median nerve, they're all be coming into the spinal cord. So a lesion anywhere from T1 to C5 are going to show up here. Does that make sense to you guys? So it could be a central lesion being in the spinal cord, or it could be a peripheral lesion being in the nerve roots if the lesion is right here. You guys get that, right? So here it has to only be peripheral. Here it could be central or peripheral. And let's look at what could be happening centrally. What do you call the tracts that make up the dorsal columns? What do we call those? Fasciculus. Or fascicula. Fasciculus what? Gracilis. And the fasciculus cuneatus. Okay, good. Which one comes up from the legs? Gracilis. We know it's the gracilis because we stand on grass, right? Gracilis, grass, feet, all that, right? And so that leaves the cuneatus from the arms. Now, which ones, let me just redraw this really quickly. Between the gracilis and the cuneatus, which ones are most medial? Which one?
Yes.
Or?
Gracilis.
Gracilis, very good. So the gracilis are most medial, which means the cuneatus is where? More lateral. Now I tell you this because it's important to know. And it's important to know because when you're taking a history on the patient, they may say something to you like, you know, I've lost some sensation on both my feet, right? My hands are okay, but it's both my feet. Now, if they lost sensation in both feet, could it potentially be one lesion in the spinal cord causing loss of sensation in both feet? Is that plausible? Yes, it is. Why? Because both tracts are right next to each other. You see that? So I could have one lesion that could affect both legs or feet, but not the hands. Does that make sense? Now, if you had a patient that said, hey, I've lost sensation in both hands, but both feet are okay, does that make sense that you might have one dorsal lesion in the spinal cord causing that?
No?
Well, couldn't that be a syringomyelia?
Well, if you had, well, let me talk about this and then talk about that, okay? If I had one lesion that dorsally that's compressing the cuneatus tracts, right, from the hands,
Oh, yeah.
what would it also have to compress? The gracilis from the feet, right? Now, syringomyelia, which is what? Because you were just asking me about syringomyelia, right? When you have an expansive lesion in the central canal, that could go up and affect this, yes? But what's going to happen, though, is that if it's up in the neck, right? Because if it was in the low back, it wouldn't affect the neck. It would have to be up in the neck, and it would have to be such that it's affecting. It would probably affect. Well, it would affect. Most likely, if it was symmetrical, the hands and the feet all together. With if you had that kind of tumor, what you typically see though in the neck is you have your anterior spinal tracts. Let me take that back. You have your spinal thalamic tracts, right? Your pain and temperature tracts, which come in and cross right in front of the central canal. And they get hit, right? With an expansive tumor. And then what will happen is you lose sensation, right? For pain and temperature. Right? And what kind of distribution?
Strong.
It is shawl-like distribution. And the reason it's just up here is because the tracts that are crossing here are in the cervical spine, right? So that's what you see in that. That's what you guys were asking about. Okay? Does that make sense to you guys?
Mm-hmm.
Any other questions? Okay, so back to this. So if I have a posterior lesion I can lose sensation if it's a big one, right? Hands and feet. If it's a smaller one, just the feet. Now, the other thing you can think about too is the blood supply to the cord. What do we call the arteries that feed blood to the spine? If you were going to name, if you were in charge of naming the arteries that fed blood to the spine, what would you call them?
Spinal arteries.
Spinal arteries, and so did they, right? So what would you call the one that feeds the anterior part of the spinal cord? Anterior spinal artery, right? And what would you call the ones that feed the posterior part of the spinal cord? Posterior spinal artery. So the anterior spinal artery feeds the first, like, 2/3 of the cord, the anterior 2/3. The posterior arteries feed what? The posterior third, right? So if I was running an SEP, right, because my patient had lost some sensation, like let's say light touch in their hands and their feet, and I thought that, and I ran it, and they had a slowing here at C5, and I knew it was a vascular condition. Which arteries do you think would be involved, posterior or anterior? Say it out loud. Posterior. Why would it have to be posterior? Because these are the tracts we're measuring, right? The dorsal columns are in the posterior, and if I had a compromise of the blood supply, then these tracts would not be receiving good blood supply, and they wouldn't function so well. Also, if I have compression on the veins that are taking blood away in the posterior, then the new blood can't get in because it's backed up, so that could affect it as well. Any questions with that? All right. So we've talked about lesions. If we have delayed responses at Erb's point and at C5, the last one is in the parietal lobe, right? Our last, or our terminal electrode, is here in the contralateral postcentral gyrus. It's in the parietal lobe. With this case, if I had delays here, and this one, you would normally have your waveform coming in at 20 milliseconds, right? So if the peak waveform is coming in at 20 milliseconds, I think that's good. But what if my peak waveform came in at 24 seconds, let's say? It's delayed. Let's say this was good, this was good, this is delayed. Now, what could you say about this patient's lesion, peripheral versus central? It'd have to be a central lesion. You guys see that? Because all the peripheral parts of the nervous system are working fine. It's the central one that's compromised. Could the lesion be in the spinal cord in that scenario? Could it? Yes or no? Yes, it could, right? But it would have to be above what level?
C5.
It would have to be above C5. Could it be in the brainstem? Yep. Could it be in the thalamus, internal capsule, or in that parietal? At this point, we probably want to run an MRI, right? Just to kind of identify exactly where the lesion is. All right, so these are the things that I wanted you to be familiar with about the SEP, because these are tests that are commonly done in the world of neurology. And since you're going to be having patients that are going to have symptoms that we're going to try to take care of, we want to try to figure out what's causing the symptoms, especially if they don't respond immediately to our initial treatments. Do you guys have any other questions on SEP? Okay. Well, that concludes this lab. You can turn that off.